Thanks to all of you for being here for the Cancer Center seminar today. And it's my pleasure to get to introduce Dr. Arjun Gupta. And for those of you who don't know him, he joined our faculty a year and a half ago from Johns Hopkins, where he did his fellowship and had previously trained in India and UT Southwestern. He's one of our rising superstars as an assistant professor in hematology, oncology, and transplant, and is really pushing the envelope as a GI oncologist and symptom management researcher and health services researcher on helping us kind of think a lot about the time toxicity of cancer. And so I'm really excited to hear his talk today. He's been very prolific with publications in JCO and the Journal of Oncology Practice, and we're really excited to hear about this work today. So welcome.
Thank you very much, Anne. And good morning, everyone. It's a joy to be here. It's my first time being in this room and on this side of the stadium, and it's beautiful. So before starting, I have no disclosures. As Dr. Blaise mentioned, clinically, I'm a GI medical oncologist, primarily taking care of older adults with advanced stage colorectal cancer, pancreatic cancer, gastric cancer, hepatobiliary cancers. And these patients, despite all the advances, still face limited survival. The average survival is often in the order of several months to a few years. This informs my research questions, which I would group into two big buckets. One is doing symptom control trials, so creating better treatments for pain, appetite loss, nausea. And then the third hat I wear is as a health services researcher. So using quantitative and qualitative skills to understand what bothers patients and their care partners and how we can create better care for them. And one of the themes that encompasses all of these aspects is this, which brings me to my professional mission, which is to improve the quality of care for people with cancer. And more specifically, for the purposes of today's talk, how to respect where and how patients spend their precious remaining time alive. This was a quote from Henry Thoreau that I read in my second year of fellowship, so 3 years ago or so, that really had a profound impact on me. This is when I started to think about time toxicity and how we deliver oncology care today. We've seen tremendous progress in cancer over the last 20 years or so. All the clinical oncologists in the room and on Zoom will recognize that every week we get emails from the FDA and the ASCO, the American Society of Clinical Oncology, updating us about new treatments that have been approved. It's honestly impossible to keep up. For example, there were 3 treatments a month approved last year, which is great. We need more treatments and more options for persons with cancer. However, and this has been going on for a long time. This is the cover of the Time magazine back in 1980, when interferon was quoted to be the wonder drug that was going to cure melanoma and other cancers. Fast forward 20 years, and we get to imatinib or Gleevec for chronic myelogenous leukemia, and that was supposed to cure cancer. And fast forward 15 years after that to the mid-2010s, and we have immunotherapy. And these drugs and approaches have definitely helped hundreds of thousands of patients, right? But as we get more liberal in how we approve these drugs and what our cutoffs are for new and novel drugs, we're also facing a plethora of drugs with very marginal survival benefits. Dr. Micheli and colleagues from Germany did a meta-analysis of over 100 drug approvals since 2003. So from 2003 to 2021, they took over 100 drug approvals by the FDA and summarized that the average survival benefit offered by these new drugs was 2.8 months compared to the historical control. That doesn't sound very impressive. I'm going to bring up this graph to tell a story. When I was a second-year medicine resident, this is back in Texas, I knew I wanted to become an oncologist. So I went to an oncology mentor in residency, and I said, hey, I have my journal club coming up, and I want to present the hottest new thing in oncology. And I want the chair of medicine, who's also an oncologist, to take note of that, and they'll write me a great letter. They said, okay, Arjun, you do this trial. It's amazing, and this drug's just been FDA approved. And so I'm not naming any drugs here, but the line in red is chemotherapy plus the new fancy drug. The line in blue is that same old chemotherapy. On the y-axis is progression-free survival percentage, and on the x-axis is time in months. And we can see here that the graphs or the lines are hugging each other. This laser pointer is not working, but if it did, I would struggle to point it between those curves, right? And yet, this drug was FDA approved. And when we look at the median progression-free survival for these two treatment approaches, new drug plus chemo versus chemo alone, this is what we find in months. So the median progression-free survival was 5.7 versus 5.5 months, with a significant hazard ratio based on statistical voodoo that the trial design did. And it's not bad enough when we start reporting and rejoicing at decimal places of progression-free survival in months. There is a serious problem with oncology when we start rejoicing and reporting 2 decimal places, right? So this is a recent abstract from the American Society of Clinical Oncology 2022 meeting. And just to take a step back, what does 0.1 month mean? I think it's very intuitive, it's 3 days, right? But what does 0.01 month mean? And the answer is 7 hours. So whether someone has a scan done before they head to work at 9 a.m. or whether they leave early at 4 p.m. after work to get their scan determines what their PFS is. And that's not cool. I think we can all agree that there's something seriously wrong with our discipline. So it's in this context of new and fancy oncology treatments, often associated with marginal survival gains, that we conceptualized this concept of time toxicity, which we say is the time costs or the time burdens of deciding to pursue, receiving, and recovering from cancer treatments. That is what we think of as the time toxicity of cancer treatments. We know that cancer care is increasingly complex. All these fancy new drugs are being approved. Cancer is becoming more and more multidisciplinary. So instead of seeing just one person, you're seeing a whole team, and that's good. We have nutrition services and palliative care and social work and all these other groups helping just the medical oncologist to care for the person. But these multiple visits can also impose serious burdens on patients and care partners. In addition, as more and more cancer treatments are approved, they also require more frequent monitoring. We might need an echocardiogram or pulmonary function tests or blood work twice a week. And instead of the predictable short-term side effects of traditional cytotoxic chemotherapy, many of these cancer treatments can have longer-term or unpredictable toxicity. So you can have pneumonitis or myocarditis, inflammation that can persist for months and years and continue to eat up patients' time. And also, due to forces such as peer influences, insurance companies, care is shifting more and more into the clinic setting or the outpatient setting. So instead of patients being admitted to the hospital for 4 or 5 days to get all of this done, that is often no longer allowed. So the burden is put back onto the patient and the care partner to have to come to clinic every single day for 5 days a week and so on. And so we, of course, conceptualize time toxicity for everyone, including everyone in this room. Your time is precious, which is why I will try to end 5 minutes early, right? But it's much more important to older adults with advanced cancer. And why? Because older adults often are underrepresented in clinical trials. We don't know if our new drugs work as well for them. And at the same time, they often experience higher rates of toxicity. And in the context of stage 4 or incurable or metastatic cancer, their survival is often limited. So when your time is limited, I think time is most precious. So based on all of this, the central question that we're attempting to answer through this time toxicity work is the survival benefit of a new cancer treatment dwarfed or influenced or eroded into by its time toxicity? And if yes, should we not be honest and upfront about this with patients? This does not make a treatment right or wrong. It doesn't make a patient's decision to pursue a treatment right or wrong. These are individual values, individual preferences. But I think currently, oncologists lack this data themselves, so they're unable to communicate it to patients, who are then unable to make truly informed decisions. Any questions so far? Anything online? Thank you. So now that I'll assume that everybody agrees that we should do this. So now that we agree that this concept is important, an important sort of junction that we arrive at is how do we measure this, right? We all agree that when time is limited, when survival benefits afforded by new treatments are marginal, we should calculate time losses and we should communicate that to patients. We all agree on that. But how should we do that and what should the measure be? So instead of reinventing the wheel, we tried to look at other disciplines to see what they'd potentially done. And prior work from many different disciplines, such as cardiology, neurology, critical care, surgery, transplant medicine, has focused on what they term as these 3 terms: days alive and out of the hospital, days alive and out of the institution, hospital-free days. And you'll notice a lot of hospital or institution. So what all of these measures are looking at is how many nights do you get to spend in your own bed? And how many nights are you admitted to the hospital or another rehabilitation or nursing facility, right? So if you're alive for 100 days and you're admitted for 10 of those days and you spend 5 days in rehab, that takes 15 days away from the 100 and gives you 85 hospital-free days or 85 healthcare-free days. And that's great. I think they're well ahead of us. They've been doing this for 20 years. But there's a reason that these disciplines focus primarily on hospitalized or inpatient days, right? When we think about these disciplines, they're often taking patients who are acutely sick or who are undergoing a one-time intensive intervention. So you come in critically sick, you get a new form of a ventilator, and the most important outcome is, in the next 90 days, are you alive? And do you get to go home and sleep at home, right? And so they've taken very short time horizons, 90 days, 1 year or so, and calculated how many nights you spend at home. And the other reason that they've focused primarily on these inpatient sources of time loss is that inpatient data are easy to calculate from claims data such as Medicare, right? So for pragmatism and for patient-centeredness in their own disciplines, they've primarily focused on nights in the hospital. On the other hand, more current work, including by some colleagues in the Cancer Center, Dr. Rachel Vogel et al., focus on very, very nuanced measurements of how much time is exactly spent in pursuing certain activities. So how much time do I spend driving to the cancer center, finding parking, which took me 17 minutes today, despite Dr. Alex Size's help? How much time do I spend with annoying insurance companies on the phone, right? So much of this new nuanced modern work is focusing on exact hours and minutes that patients spend and how much burden does it truly impose on patients during that time. And that is fancy and great. It needs to be done, right? The trouble with doing that in a clinical scenario is that how do you collate all of this information? How do you communicate it to patients, right? If you start telling patients, if you do this drug, you will spend 84 minutes on the phone and 24 minutes online and 13 minutes on my chart, they are just going to lose it. I am losing it myself thinking about this, right? And this concept of too much nuance leading to clinical non-adoption is not new. Many smart people in oncology have tried to do this for 30 years. So this was a paper published by Dr. Gelber et al., now almost 30 years ago, where they came up with this new measure known as Q-twist. So Q-twist not only sounds cool, it takes into account your quality of life, your time without toxicity from cancer treatment, time without toxicity from the cancer itself. So it's a good measure of quality of life and quantity of life. But if I ask clinical oncologists in the room and on Zoom if they've ever used this in clinical practice, I know the answer is going to be a resounding no. We see all these squiggly lines and we have no idea how to calculate this, let alone communicate it to patients. So whatever measure that we come up with to talk about time toxicity needs to be easily calculable and it needs to be easily communicable to patients. And so for those reasons, the measure that we came up with is days with physical healthcare system contact. Any day that you need to get out of bed, get into a vehicle, and come to a facility, whether it be clinic or a hospital or an infusion center or the emergency room, for any reason, for any length of time, is a time toxic day. So we see here a community dwelling older adult who has to go for blood work or infusions or radiations or chemotherapy to clinic or to the emergency room or urgent care or be admitted in the hospital. Each of these represents a source of time toxicity. And each of these healthcare contact days counts as a time toxic day. Now, the reason we did this is that one can say that, oh, a lab day is just, I go to the lab and I get blood work drawn and it takes 10 minutes. And that's a very clinician-focused, non-patient-centered view of looking at things. If you've actually been a patient yourself or speak to patients, you'll know that your day is not just 15 minutes, right? You need to figure out who's dropping the kids off, who is driving you, where are you parking, the wait line at the infusion lab, your portacath needs to be accessed. Oh, it's clogged. We need to inject some TPA to dissolve this clot. Oh, the nurse just went on his or her lunch break. And this entire process can take up half a day, which can represent an entire day's loss for the patient and his or her care partner. And this may seem very airy-fairy and we're sort of making it up. So Dr. Alex Sai, one of our HEMA fellows, and us, we decided to look at this within the CSC, which is our clinic, right across campus. These are unpublished preliminary data on how long patients actually spend for routine encounters in the oncology center. And these are just very preliminary data that we're starting to get, that even for patients who are coming in for labs, just their time spent in the lab unit itself is 45 minutes or so, right? And there's a lot of waiting involved. There's parking, transportation, driving, all of that. And when you bunch that all up, and when we're doing qualitative interviews with patients, they're saying, yes, I cannot do anything else on these days. So for those reasons is why we've come up with this measure that each day with in-person healthcare contact in a clinic, in any healthcare facility, is a time toxic day. And so this is how we envision this concept going forward, is that especially for people with advanced incurable cancer who are facing a limited prognosis, their overall survival is nothing but the days from diagnosis to death. And each day alive can be labeled as either a time toxic day or a contact day, or a day on which they have healthcare contact, and all other days when they get to be home completely gets to be a home day. And so your overall survival is nothing but the sum of home days and time toxic days. So how might these data apply to someone in the real world in clinic? So let's consider Mrs. M. Mrs. M is a 85-year-old woman. She's a retired nurse and a loving grandmom. She's community dwelling. She lives in her own home, and her son and grandkids live down the street. She's just been diagnosed with stage 4 pancreatic cancer, and genetic testing has revealed that she doesn't have any actionable molecular alterations that would render certain new treatments, render her tumors very sensitive to certain new treatments. She knows her estimated survival is in the order of months, and she knows her time is limited. When you probe her about her values, she says that I want to stay close to home. I want to be with my garden that I've spent 5 decades nurturing, and I want to be with my grandkids as much as possible. And her values include avoiding the hospital as much as possible. When we traditionally present treatment approaches to Mrs. M, we would present things as just the first 3 columns on this figure. We would say, on average, you would live 8 months with chemo and 6 months without chemo. But what we don't explicitly understand and so communicate to patients is what is the time costs of doing that treatment, which in some cases might overtake the marginal survival benefit of that treatment. And so our call for the time toxicity concept is just that we start calculating and communicating this last point, this last column, is how much time do you actually get to be home? And this is what we proposed in an earlier commentary this year in the Journal of Clinical Oncology, framing this concept, that information on time toxicity and home days can supplement each other to enable that patients can make the best decisions for themselves. Now, as we talk about this measure, like anything we measure, it's not perfect. We ourselves acknowledge the several limitations of considering any day with healthcare contact as a time toxic day. First of all, not all home days are good, and not all time toxic days are bad, right? Healthcare is necessary, and some days you need to come in. And we're not saying that every time toxic day is unnecessary or bad or should not be done. Secondly, we are currently considering this as a dichotomous measure, time toxic or not. There is no quality weighing of days that we're doing, right? But we know that when you're very, very sick and in the hospital is perhaps not the same as a lab day, right? But for the purposes of pragmatism and communicating a measure to patients, we've sort of accepted this limitation. We also know that time toxic days, in essence, represent healthcare use. And it's important to recognize that certain populations and individuals face structural racism and other barriers to care. And so we should be very wary of interpreting less time toxic days or less contact days as universally good. We first need to ensure equitable access to healthcare when interpreting any sort of time toxicity measures. We also need to make sure that a time horizon for looking at time toxicity is sufficiently long. Imagine a patient with pancreatic cancer who develops cholangitis or an infection of the biliary tree. This can be life-threatening. They need to be admitted for a procedure to relieve this obstruction, and that hospitalization lasts 4 days. And this will be considered time toxic. But if they hadn't done that procedure, the patient would likely have died. And so doing that 4 days of upfront time toxicity may prevent lots of downstream harm and an early death. This measure does not clearly account for care partner burdens. So we're only looking at if a patient comes into the clinic or facility, but if they're spending time at home or the care partner is spending time on the phone with the insurance company, etc., we're not clearly measuring that. So imperfect measure, and we're doing qualitative work with patients, with care partners and clinicians to understand what they think about this measure, if and how we should refine this measure, and how we can edit this while still remaining very, very practical. So before we go into the clinical trial scenario, which is sort of the bulk of this time toxicity work and our vision for time toxicity, as we started to propose this work over the last couple of years, a genuine question came from the oncology community that, okay, we want to measure treatment A versus treatment B in clinical trials, and that's good. And why can't we also measure this in the real world? Why can't we measure how the University of Minnesota is doing, for example, and how we deliver care to our patients? And we said, okay, let's start looking at that. But there's a couple of very important points to consider before we start interpreting time toxicity in the real world or retrospective setting. So the first is the data can be heavily confounded. So what does that mean? So if in the real world, a patient gets treatment A versus treatment B, we should be careful not to directly compare their time toxicity with each other, because the reasons patient A and patient B got treatments A and B, they're very, very different people to start with. So this should, ideally, the time toxicity of treatments should only be compared in a randomized controlled setting. And like we discussed just a little while ago, that care delivery in the real world represents our own healthcare systems and access issues, right? So anything that is in the real world should be interpreted in the prism of your own healthcare system. So with those limitations, let's chat about some data that we've collected over the last few months. Before that, just as context, this was work by Dr. Banj et al. In the Journal of Clinical Oncology Practice a couple of years ago, where they looked at approximately 200 patients with stage 4 pancreatic cancer. The median survival for these patients was 7 months or 210 days. And what Dr. Banj and colleagues found is that of those 210 days, patients spent a median of 22 days coming back and forth just for receiving chemotherapy. So 10% of your days alive were spent coming back and forth for chemotherapy administration. Okay, so that's sort of the only benchmark or the only initial data for this concept that existed. And so we started to look at our own data. We took approximately 809 patients with advanced stage GI cancers treated in the Fairview Health System from 2011 to 2019. We only included decedents, so people who were diagnosed and deceased within this 2011 to 2019 timeframe in this analysis, and only patients who got care within our Fairview healthcare system. And we did this so that we have complete data on all patients, right? If you would have just taken everyone diagnosed and they're still living, we don't know how their time toxicity over their entire journey manifests. And the reason we stopped analysis at the end of 2019 is that our care delivery systems took on a massive transformation in 2020 because of the COVID-19 pandemic. So this sort of represents the most comprehensive evaluation in a contemporary era while remaining pre-COVID. And so we found that of these 809 patients, the median age was approximately 70 years. Around half were men and half were women. Around 85% of individuals were of white race. Around a third of patients each had colorectal cancer and pancreatic cancer. The rest had hepatobiliary cancers and esophagogastric cancers. And 1/3 of these patients never received any chemotherapy. And that's just because maybe they were too sick, to receive chemotherapy, or they decided not to, that it wasn't worth it. So in these 809 patients, our primary outcome was what was the median number of days that they were alive? What was the median overall survival? And the numerator was what was the median number of time toxic days? How many days did they spend in contact with the healthcare system? And the bottom number is 175, 6 months. This is in line with a lot of what retrospective data shows across institutions, across Medicare. So in the real world, people are just living for 6, 7 months. This is seen very commonly. Whereas in clinical trials, these very patients seem to live for 2, 3, 4 years. And that's a separate discussion of why clinical trials have such better results than the real world. But we'll stick to this conversation for now. And the median number of time toxic days was 45. And when you divide this, you get 25%. That means when accounting for all causes of healthcare contact, patients with advanced or stage 4 GI cancers are spending 1 in 4 days alive with healthcare contact. Let's think about that. 1 in 4 days alive when you're living for 6 months on average. That's pretty sucky. And we also did beta regression analysis to see that what socio-demographic and clinical factors were associated with a higher proportion or a higher percentage of time toxic days. We found that older adults had higher rates of time toxicity. This may perhaps indicate that they're at a higher risk of side effects. It might also indicate that there's perceived or actual differences or preferences in their ability to attend appointments. So younger patients may be more in the workforce, they may have more childcare responsibilities and may not want as much healthcare. So we did not assess that patient-centered appropriateness or whether this care was goal concordant or not. But these are just some things we noticed. We found that Black individuals had higher rates of time toxicity. This may potentially be explained by the lack of ability to pay for private help at home, for example. So when you cannot have home services, what do you end up doing? You end up coming to the hospital, right? It may also represent their inability to actually harness the healthcare system and inability to be able to coordinate appointments, resulting in more uncoordinated care. We found that the rate of time toxic days increased. So from 2011, 2012, it kept increasing. It was the highest in this later part of the study period. And this just represents that our care is getting more and more complicated, right? We're asking patients to do more and more, resulting in more time toxic days. We also found that cancers that are usually associated with higher symptom burden and higher complications relative to other cancers on average had higher time toxicity, and that patients who did not get chemo actually had higher time toxicity. So this might seem counterintuitive, but again, these are patients who are not getting chemotherapy, likely because they are too sick. So the average survival for this group was 2 months. So these are patients who are diagnosed, they may have comorbidities to start with, and they're never fit enough to get chemotherapy and spend a majority of their time within healthcare facilities, often inpatient. So these are just some factors that we found associated with a higher percentage of time toxic days. And we also looked at the trajectory of time toxicity over time. So we know that the average rate is 25%, but how does it vary over the course of people's illness? Now, how do we analyze or visualize this data when different patients are living for different amounts of time? So some patients are living 1 month, some are living 6 months, and some are living 2 years. And so what we did is we standardized each patient's survival, right? So whether you lived for 1 month or 6 months or 3 years, we stretched everybody's graph out to the same and then plotted that on a curve. And this is what it looks like. So on the y-axis is the percentage of contact days or time toxic days. And on the x-axis is standardized time since diagnosis. So sort of a decile of your survival. So 0, 10%, 20%, 30% of your lifetime, all the way to 100%. And we see this U-shaped curve emerge, which has never been described before in the context of time burdens, right? So when you're first diagnosed, more than 1 in 3 days alive in your, say, first month after diagnosis are spent with healthcare contact. So this is the time when you may have a symptom crisis that brings you into the hospital. You may be having gastrointestinal bleeding that leads to the diagnosis of colorectal cancer, or you have obstructive jaundice that leads to the diagnosis of cholangiocarcinoma or bile duct cancer. This is the time you meet with the medical oncologist, you meet with the surgical oncologist, you meet with the radiation oncologist with palliative care, you get a portacath placed, you come in for chemotherapy teaching. Very, very intensive phases. And then there's a more moderate middle phase before, as your cancer grows, as the chemotherapy stops working, these rates go up towards the end of life. And although this is novel in the context of time toxicity, a very similar curve has been described for symptom burden, so how patients report their quality of life, and also financial toxicity or economic burdens imposed by cancer care. So in other words, time toxicity is just another way of communicating to patients how sick they are. And we also hypothesized that this curve, even though we managed to standardize this and fit this in a cubic spline, the trajectory of patients may be very different based on how long they live, right? So someone who's living 2 months may be spending all their time in hospital, and their time toxicity may be universally high. Whereas someone who's a long-term cancer survivor, say living 5 years, their time toxicity curve may look very different. So we actually grouped patients into cohorts based on their overall survival and plotted this out. And this is what we see. Again, on the y-axis is healthcare contact days, and on the x-axis is survival in months. And patients living 0 to 1 year, 1 to 2 years, 2 to 3 years are bucketed. And we see that this U-shaped pattern remains conserved, indicating our need to better support patients during this initial intensive phase and the later intensive phase across survival. If we think that this is a one-off, okay, I'll just pause. Dr. Blaze has a question. Perfect. So Dr. Blaze is asking that some of these contact days or time toxic days might be good, and some of these contact days or time toxic days might be bad, and if and how we can reconcile this or consider this. And I would say this is the biggest limitation of this work, especially retrospectively. I think we still don't understand how much care is necessary for these patients. So we have no idea what appropriateness is. One of my points to come out of this work in the next few slides is a need to benchmark appropriateness. So we need to understand what is standard. We know some healthcare is good, too much is bad, but we have absolutely no idea what those limits are. And I think if you please get me grant funding, I will do this over the next 5 years. If we think that our UMN data or our Fairview data might be a reach, we did this exact same analysis. We have very preliminary data from the VA. So we looked at the same exact years, 2011 to 2019, persons with stage 4 cancer, and we looked at their time toxicity over time. And this is the graph that we're getting, right? So we're looking at more of the clinical characteristics and associations. That work's not been done yet, but this U-shaped curve is being seen across populations. And then just to Dr. Blaze's point about how do we actually act on these data, or how do we understand or interpret and actually improve care with these data, let's take a look at a different population. Let's take a look of people who are cancer survivors. So the NCI, the National Cancer Institute, defines survivors as from the point that cancer has been diagnosed. But in this study, we have on average took people who were 5 years out from their cancer diagnosis, so longer term survivors. And we looked at how many days did they have in contact with the healthcare system in 1 year. I want us all to do a mental exercise. What do you think the average adult in the US spends with healthcare contact in 1 year? If anyone's brave, shout it out. If not, it's fine. An older adult, so over the age of 65, how many days do we think they spend coming in for blood work, seeing the doctor, things like that? Any guesses? 15 to 20, I love it. Anybody else? That's actually very close. It's 10 days. So an average older adult spends 10 days coming back and forth every year, right? And in our data for cancer survivors, we found that it was 20 days, right? So double the rate of healthcare exposure. Remember, this is the healthiest cancer population that we can find. These are not people receiving active cancer-directed treatment. They're not so many years out that they're approaching their 80s and 90s when they're getting very sick. This is usually your 70-year-old older adult population. But the point I wanted to raise is we looked at the variation in contact days for this population by hospital referral region. So the US is divided into 310 hospital referral regions, geographical, and we wanted to assess the variation in contact days. And we see here this graph, the legend is on the right, and only approximately 100 HRRs, or hospital referral regions, are represented here because that's where the patients were. But we see this wide variation in how much healthcare people are getting. And Minnesota doesn't look too good up there. So we have a lot of work to do, which we'll do. Right? But the point is, before we can get into what is good, what is bad, we first need to understand how much healthcare is good, which has never been done, I think, for the cancer population. So all of this is to say that this retrospective work can guide us through all of these points, is coordinating better care, benchmarking appropriateness, and communicating expected burdens to patients so that they can make more informed choices. This is all based on retrospective work. And now let's move to clinical trials. So clinical trials represent the most beautiful place to look at time toxicity because they're already collecting vast amounts of data in a prospective randomized way, right? And one can look at clinical trial publications and protocols and estimate what the average patient on the clinical trial experienced, right? So you know the median survival is this and the median toxicity rate is this, but it involves making a lot of assumptions. And so a more accurate way of doing this is actually looking at patient level data in clinical trials. So reconstructing each patient's course on the clinical trial to mark each day on the trial as time toxic or not. So we did this in a clinical trial known as the CO17 clinical trial. It randomized over 600 patients with stage 4 colon cancer to get weekly cetuximab infusions or best supportive care. And these were the overall survival results reported. The people who were getting weekly chemotherapy infusions lived on average 6.1 months. The people who just stayed at home and got symptom control lived for 4.6 months, or a 1.5 month or 6-week survival benefit. We went through each patient's trial-related forms, which reported if they had healthcare contact or not, and analyzed home days and time toxic days and split that up. And this is what the data look like. So we see in the first row is OS, or overall survival, which is 6.1 versus 4.6. But when we look at the time toxic days, they were statistically significantly higher in the cetuximab arm. And home days, the number of days that you stay at home, were statistically similar between arms. But I want you to focus on the last row, the 18% versus 6% contact days rate. Whether you present these clinical trial data to patients like this, or like this, will probably elicit very different reactions and choices from patients. And that's okay. And our call is only for clinical trials to start doing that. Before getting too pessimistic, I want to say that time toxicity decisions can actually support people's decisions to pursue chemotherapy. I recognize many of the people in this room are basic scientists and translational scientists. So let's talk about some KRAS. So later work showed that this cetuximab infusion was actually only active in patients whose tumors were RAS wild type. If your RAS is mutated, this chemo doesn't work, right? So let's do a subgroup analysis of patients with RAS wild type tumors. And we see this is for all comers. And now we'll focus on RAS wild type. And we see here immediately that the overall survival benefit, instead of being modest in 6 weeks, is now almost double, right? And although time toxic days are higher in the cetuximab arm, so are home days, supporting some patients' decisions to pursue chemotherapy. So time toxicity need not always be pessimistic. And in the interest of time, I'll move on. Dr. Blaze. Perfect. So Dr. Blaze's comment is that clinical trials, because they're collecting such high quality, good data in a prospective manner, will also allow us to understand reasons and appropriateness and exact sources of healthcare contact. So we're doing qualitative work. So speaking to patients, the most important stakeholder, their care partners and clinicians, to understand their perceptions of all of this. We're launching discrete choice experiments, which are a form of choice modeling, where a consumer, in this case a patient, is presented 2 or more options, and they get to choose what they would pick in something like this. And by asking several versions of these questions, we can understand what patients really prioritize in the context of limited time and what influences their decision. We're also now engaging with oncology cooperative groups such as Alliance, ECOG, and SWOG to potentially deploy this prospectively in future clinical trials instead of trying to retrospectively do secondary analyses of completed clinical trials. And our vision for time toxicity actually mirrors what has been done for financial toxicity. I assume several of us have heard of financial toxicity. But just taking a step back in 2008, 9, 10, no one had coined the term financial toxicity. The out-of-pocket costs and bankruptcy associated with cancer care was accepted as a side effect. And since being named and shamed and intervened upon, there's been a lot of understanding and focus on financial toxicity. And our hope is that for the next 10 years, time toxicity grows at a similar speed and scale to respect how and where patients spend their time. I also think as we move through this and respect patients' time, especially for clinicians, the most important thing to do is to respect our own time, to have more autonomy, because we can only respect patients' time and guide them better if we have enough time in clinic. And this is being eroded into because of many, many structural and administrative issues in medicine. And ultimately, the goal is for such cartoons in the New York Times, which depict the 5 stages of grief with nivolumab or an immunotherapy or a cancer drug thrown in, which is a cartoon, but it truly represents desperation oncology and so much that's going on with oncology, to replace it with truly person-centered care, where a person here said that his last wish is to go fishing, couldn't leave the hospital, so his family arranged this portrait of him fishing. And if we can respect what patients want to do as they approach the end of life, I think the oncology community would have done their job. So thank you very much for your time. and we'll take any questions. And these are the mentors that I want to thank. Dr. Stacy Dusatzina at Vanderbilt is a health policy expert. Dr. Ann Blaze, our division chair, and Dr. Christopher Booth at Queen's University in Ontario. Thank you. So the first question is by Dr. Manish Patel. He asks, are you looking at time toxicity of responders versus non-responders? And I assume duration of response would influence the time toxicity. So yes, absolutely. I don't think we found the appropriate trial to do responder, non-responder analysis, but these are absolutely the questions that we should be asking. I would say that many secondary analyses that we're attempting to do lack sufficient data for us to calculate time toxicity across trials. So that is why doing this prospectively in future work may perhaps be more appealing, because patients want to know not just what is the average, but am I likely to quote unquote respond to this chemotherapy? And if yes, what are the chances that, or what is the extent that it'll help me? So doing this in sub-cohorts of the population absolutely makes sense. And the second question by Dr. Luo, just give me 1 second. So Dr. Luo is suggesting that instead of taking overall survival as the primary endpoint in many clinical trials, can we sort of take a version of time toxicity as a primary endpoint in clinical trials, perhaps home days as an endpoint in clinical trials? And Dr. Luo, I love you. That is exactly what we want to do. So if I have money and power in cooperative groups in advanced cancer, I will have OS or overall survival as a secondary endpoint and have home days as a primary endpoint. Some of the work that we are doing now is to understand the distribution of home days. Does it also follow a normal distribution at all, or is it not normal? And is it skewed? Because that will help with statistical design for future clinical trials wanting to explore home days as a primary endpoint. A third question is by Dr. Jansen. What about expanding your measure to represent more of a burden of care to include time toxicity and financial costs in addition to other factors? So that is, I have many dreams, but that is also a dream, is to come up with a comprehensive measure of logistic toxicity, as we're starting to name it, which takes into account time, finance, on phone with the insurance companies. This is all, I think, 5 years worth of work. So maybe when we have this talk again in 5 years, we'll have some data on that. But thank you. I've been thinking about this for 2 or 3 years, and you've already come up with the 2 or 3 things that I think are the best ideas. Dr. Yee.
I actually lots of questions, but I'll try to boil it down to 2. So the first one is, do you think establish or measurement of time toxicity is relevant to people being treated with curative intent? So, let's just say, just take the extreme example, somebody getting CAR T cells for a relapse B cell neoplasm where we think we're trying to cure them and they spend a lot of time here, as opposed to the person who just goes to hospice.
Very difficult question. I assume everybody on the audience, even on Zoom, heard it. The question is, should we think about time toxicity in the curative setting? I think it is a more difficult question than in the advanced cancer setting where we know the intent. I would say even curative intent, Dr. Yee, can be where you have a reasonable likelihood to succeed, and one where I think we're a lot more desperate. I think measuring time burdens of expected therapies and communicating that to patients, sort of to Dr. Patel's point, that you have a 10% chance of response and cure. And if that happens, this is what will happen. And there is a 90% chance that despite this curative intent therapy, things will go awry. I think just communicating that will help patients with decisions. I will also say curative can have many different flavors. There is the a sort of what you're mentioning, someone with a relapsed refractory hematological malignancy doing salvage CAR T therapies is very different from a person with stage 3 colon cancer who is deciding between adjuvant chemotherapy or not, where the sort of disease-free survival may vary by 3 points or 5 points. So that is a very different population. One is more life and death, and one is more a few percentage points. But I think in general, time toxicity is applicable to all of these contexts. Just in terms of prioritizing it, I think palliative settings should be first, and then we'll move on to the curative settings.
Be quick. Just make this easy for you.
One of the things Arjun and I have been talking about, and I've challenged actually some of our other investigators like Demea Dosa, is does the time toxicity in clinical trials and the curative intent actually impact some of our racial ethnic disparities and recruitment on studies? We all know that it's very difficult to accrue patients to clinical studies. And if you're talking about extra burden of appointments and time away from work or needing to get childcare, that's something that we've been having conversations about, just exploring in the curative intent and how some of our racial and ethnic populations, how they view that. And so I hope that some of that work will come out too.
So the second question is something you've touched on a couple of times today, and it really relates to how patients feel about the time spent. So as you know, we're collecting a lot of patient-reported outcomes through other types of toxicities. And I don't think any of the measures I've seen incorporates any question about, how do you feel about the 5 hours you spent waiting for your doctor to see you? And I bring this up sort of as an anecdotal story. When I was a junior faculty member at the VA in San Antonio, they used to tell everybody's clinic appointment was at 9 o'clock. Everybody came at 9 o'clock and they sat there all day. And to a man, and it was all men, they didn't care. They actually enjoyed the time they got to hang out with their friends. So if you would have asked them a patient-reported outcome, they would have said, "No, this is fine. This doesn't bother me," or it was not. I value this equally to the time I spend at home, or more.
Thank you. So Dr. Yee's point is very well taken. It's something that Dr. Blaze keeps reminding me that many patients find it comforting and social to come and chat with their infusion nurse or with friends at the VA, which I totally relate to. I did my residency in Texas as well, and Texas veterans love hanging out at the VA. The point, Dr. Yee, is great. We are doing qualitative interviews to establish that, and there are many merits to time toxic days or contact days. The whole point is, can we objectively communicate it to patients so they can make their own decisions? Let me give you an example. I say, if you do this approach, you will come in for 37 of the next 90 days on average, versus you do this approach, you will come in for 3 days out of the next 90. Very objective data. That is all we're saying by time toxic days or contact days. Now, a patient might live 2 blocks away and enjoy the free coffee in the waiting room and have many friends. And they will say, I love the 37, let's do it. And the other patient is driving 400 miles one way from rural Dakota. So I think it's just about having this information for them to make more informed choices.
All right, are there any more questions? Oh, one at the back, hang on.
Okay, so I guess I have a question excuse me. So with the time toxic days, it seems like at least right now where we are as it develops with the data we have, it's really based on informing the decisions of the patients. But what about for the clinicians? Like if we know they're going to have X amount of time toxic days, what can the clinic do to minimize that? And how can we apply that to the way we care for our patients? Can we, for example, increase mobile care? And are there ways that we can reduce time toxic days by having like at-home nurses or like heavily investing in like mobile oncology or something like that?
Thank you. You've answered your own question, which is awesome. I think you're right that all of these data should guide local quality improvement efforts. Some of the preliminary thoughts in qualitative interviews that we're hearing from patients about how do we make this better, and also from clinicians, number one is more coordinated care. So having a dedicated patient navigator or scheduler who can bunch your appointments together. That is sort of the lowest hanging fruit. A very common theme in our qualitative interviews is, why do I have to come in 3 times this week to the exact same spot? And secondly is understanding why we do things a certain way, right? Why is it that, for example, cetuximab, the drug that we spoke about in the clinical trial, was given weekly, even though there's been good evidence for 5 years before that clinical trial was envisioned that a once in 2 weeks infusion is equally good. So we do certain things in oncology just because that's the way it's been done, and so we can modify our own practice. And to your point about home-based care, many patients and care partners love it, and we should absolutely support providing more of that care at home. Many absolutely hate it. And by doing more home-based care, we may actually overburden unprepared patients and care partners. So I think it's just understanding who wants that and who doesn't, and actually making it happen for patients. Just as Dr. Yee said, some patients love telemedicine appointments, right? They're in their couch, in their pajamas, and they love that. And others say, I haven't seen my oncologist, and this is awful. So understanding patient preferences and matching that is the way to go.
Thank you very much. It was really a fun discussion and really exciting work. So thank you for being here.
Thank you, everyone.